afternoon. I hope you all had a great Thanksgiving holiday. Thank you for joining us in our session for today. Welcome to our series that's called Ask the Docs. And this is a live question and answer session for 30 minutes where Dr. Rogers and I make ourselves available to the public to answer questions on specific topics on regenerative medicine and innovative cell therapies for orthopedic conditions. So every session we have a special topic, and in this session, our topic would be the use of PRP and cell-based therapies for spine pain. So if you're joining us through Zoom, you feel free to write your questions in the chat box here. There's a little chat icon at the bottom of your screen, and you can go ahead and start typing your questions. If you're joining us through Facebook, you can type your questions in the comments section and we'll answer them as they come. If you have questions of a more personal nature, we would prefer to answer that through email or by calling us, and we can discuss it in more detail. So without further delay, I'm going to have Dr. Rogers make a brief introduction on our practice, San Diego Orthobiologics Medical Group, before we begin.
Great. Hi. Thank you for the introduction. And thank you for those of you that are joining us today. And we'll spend the next half hour together answering your questions. We can actually already see questions starting to roll in. So that's really great. Thanks. And we're going to get to all of those. Both Dr. Almbach and I are board certified in physical medicine and rehabilitation. We've done fellowship training in non-surgical spine care. And so since 1993, I've been treating, common spine injuries without surgery for patients who don't need surgery, which, as you might imagine, is the vast majority of people with spine pain. Very few people actually do need surgery, but those that need it, we refer them to our spine surgeons. The advent of cell-based therapy is very exciting. We're going to talk about PRP, which is platelet-rich plasma. We're going to talk about some other cells and molecules that have been shown to be effective for certain specific conditions. We want to speak as specifically as possible because despite the fact that more than 80% of Americans have back pain at some point in their life, you can bet that not every case is going to be the same. And so even though I've treated tens of thousands of people with spine pain over the last several decades, I can honestly say I've never seen two spines that are exactly the same. And so we really do bring a customized approach to each patient. So I'll let Dr. Almbach talk a little bit more about some of the biologics that we have found to be useful, and then we'll get to your specific questions.
All right, so we do have some questions that have been previously submitted to us. But before we start, I would like to define what PRP is and what are cell-based therapies. PRP, as most of you who are joining already know, stands for platelet-rich plasma. And it's a highly concentrated amount of platelets in a solution of plasma. And the reason why we're interested in platelets is they contain thousands of growth factors that are involved in healing and tissue repair. So we're creating this solution that has a more concentrated amount of these growth factors that are naturally occurring in your body. Cell-based therapies, on the other hand, has a different set of cells that are also involved in tissue healing and repair. These cell-based therapies are derived from either your bone marrow or your adipose tissue or fat tissue. And one of the cells that are in this mix is called adult stem cells. And again, as a lot of you probably already know, stem cells are unique cells in the sense that they not only make copies of themselves, but they also turn into or become cells that are needed or tissues that are needed by the body. For example, cartilage cells, tendon cells, etc. So those are the two cells, two treatments that we used in the clinic. And we use these therapies that are autologous, which are derived from our own body. And we can go into more detail into the other kinds of stem cells that are out there. But let's go ahead and answer our first question. Dr. Rogers, how do you prepare this PRP and cell-based treatments?
So the first thing I'll say is not all PRP therapies are the same. And so just like I told you that every patient is unique, the biologic that we use is also unique. And what I mean is when we draw your blood, we're getting red blood cells, white blood cells, platelets. We can actually spin the blood in a centrifuge and then isolate layers of those cells and select from those layers. So for example, if we want a lot of platelets, we can select from the layer that has most of the platelets. If we want a lower platelet count, we can do that as well. The plasma is the fluid. If you've ever had a blister and you see fluid, that's plasma. And in that plasma are all the food molecules that you ate for breakfast this morning, as well as a lot of hormones, electrolytes, proteins, different orthobiologics that have been shown to have different effects. And so we can select that as well, depending on what our goals are. For the spine, for example, we don't want to inject red blood cells or white blood cells into the spine. And so we prepare a kind of PRP solution that has virtually no red or white blood cells in them. So we have, behind me, you can see our lab where we have multiple centrifuges. We have a cell counter, we have a hood for processing tissue in a sterile manner, so that when we create this solution, it's really customized for what we're trying to achieve. But it's really, in most cases, nothing more complicated than simple centrifugation process and then selecting out using pipette and then coming up with the ratios of plasma and platelet.
So in connection to that, Dr. Rogers, there's a question here about how many cases of PRP have you done and what is the success rate for your practice?
Oh, I see. Okay, so well, I started treating patients with PRP more than 12 years ago, maybe 13 years ago. My first patient was actually a friend of mine, a golf instructor, one of the top 50 in the world, who had tennis elbow. So he tore the tendon in his elbow, and at that point, there was one paper from Stanford that showed that PRP might be effective for tennis elbow. So we treated him, and he did get better, and he's still better, and we, still play golf, and his elbow feels good. And so since then, I would say, I don't know, thousands of PRPs. I actually have not counted. I know after my first 2 years, so from maybe 2007 to 2009, after about 2 years, I collected all my, I had my medical assistant call all my patients that I had treated within the last 2 years. And I asked them, are you better? If you're better, how much better are you? And are you satisfied with your care? And this was for all comers. This was, tennis elbow, knee arthritis, different back injuries. So a very heterogeneous group. And our overall success rate was 75%, and 75% improvement as well, and 99% satisfaction with our care. So they liked us even though we didn't get all of them well. I think it's important to note that these were patients that had tried many other things prior to PRP. So they'd had cortisone injections, they'd had physical therapy, chiropractic, many other things. So it was kind of a tough crowd, these were tough conditions. So to get, 3/4 of them better for that length of time was pretty impressive. So that motivated me to start this clinic and really just dive deep into the science and I just realized that that's the future of our profession. So we can go by each diagnosis and say, what's the success rate for, say, mild arthritis of the knee or moderate arthritis or severe arthritis. Obviously, the more severe the condition, the success rate is going to be less. And it also depends on how you define success. So is it what percentage of patients get better? So for example, we did a study where we used fat cells for knee arthritis, severe knee arthritis, patients that were trying to avoid knee surgery. 92% of them were able to avoid knee surgery at 3-year follow-up. If you say, what is the success rate for PRP in a disc in the spine, somebody who has a disc tear? Well, Dr. Ambach has some data on that from a study that she performed. So I'll let her tell you about that. So when we have these conversations with our patients, we're very specific about what success means, as well as what are the patient's goals. Are we going to be able to get them back to tennis and golf and running and gardening and all the things that are important to them?
Also, Dr. Rogers, we want to tell them about Data Biologics, which is this registry that you co-founded, wherein we collect objective data on the functional outcomes of our patients undergoing these regenerative procedures. And that way, if a patient asks us, what is your success rate for this particular procedure, for this particular condition, we have real-time data that we can present to our patients with regards to how we did with these procedures. So,
yeah. And actually, what we should do when we have our next Ask the Docs, we should figure out a way to bring up those graphs so that people can see. So people can say, "Hey, what's your success rate with a facet arthritis in the low back?" And we can show what our data is, and say, "Hey, you've got 67 patients with 1-year follow-up, and 83% of them are X% improved." That's the kind of information that people need to make a decision, because these treatments are not covered by insurance. So they're making a decision that's going to affect them financially. And, there's a big difference if you have a 90% success rate versus a, 50% success rate. So
right.
That all goes into it.
Okay, next question. Between mesenchymal stem cells and PRP, how do you decide what to use?
So let me just be clear. Obviously this is an informed viewer. They understand what mesenchymal stem cells. Mesenchymal stem cells are a specific type of adult stem cell that has been shown in the lab to have the ability to differentiate into mesenchymal tissues. So it could be bone, tendon, cartilage, muscle, fat, even nerve, actually. But that's not really what happens in the body. When we inject these cells into the body, they have what's called a paracrine effect. They secrete molecules that stimulate tissue growth. They decrease inflammation, they decrease pain. This is actually how the cells function in the body. Those cells, when we inject them, they don't stay in the body for more than 3 to 6 months, but they impart a biologic effect. They start a process that jumpstarts the healing process in those tissues. So the other thing I'll say is that we do not inject just pure mesenchymal stem cell. In other words, we don't have a little bottle that says 10 million cells and then we inject that, although we are obviously working towards that goal with our research. What we're talking about here is using your own blood, which does not have stem cells in it typically, or using your own bone marrow, which does, or your fat tissue, which does have cells in it, but we know that there are other cells in that tissue. And so it's really a tissue transplant that we're performing, not a pure stem cell procedure. But to answer your question, how do you decide when to use PRP, how to use a cell-based tissue transfer process? It really has to do with, more often than not, the severity of the injury. So again, if you have arthritis in the back and it's mild, PRP should be sufficient. If you have a more severe arthritic condition, you're probably going to want to use cells from bone marrow, which not only have platelets in them, but they also have these mesenchymal stem cells in them. Same is true for disc degeneration. So if you have mild disc degeneration or a small disc tear, PRP has been shown in prospective randomized clinical trials to be effective. Whereas for the more severe degenerated discs, you're going to probably want to use a bone marrow concentrate. And I would say we're still in the phase where this is more art than science, although we do have a lot of science behind us. We have clinical studies, but there's a lot of work to be done.
So speaking of the discs, as you know, the discs are this cushion, which is made of collagen and gel-like material that cushion this individual vertebrae or individual bones in your spine. And there's a question here with regards to how PRP and stem cell works in the discs. There's several things that happen in the discs as we get older. The discs get drier, we lose some of that hydration or that gel-like nature or the cushion of the disc. We lose some of the cells, which to begin with is already limited in the discs itself. The environment in the disc is just very not friendly to the cells in general. It's an acidic environment. There's a lot of changes that happen over time. And when these things happen, it can create not only drying of the discs, but bulging out of the disc because we lose some of that support tissue in the disc, which makes it more amenable for cracks or what we call annular tears. It can also create changes in the bone that is underneath the disc, which supports it, which we call the subchondral bone, and it can create some edema or swelling underneath that. So the way that these cell therapies help with that is they've shown in studies, both in animal studies and experimental studies, that these cell therapies, number one, it decreases the inflammation. So it acts like a cortisone. If you do a cortisone injection into your knee joint, decreases the pain and inflammation. That's what it does, is decreases inflammation. Number two is it increases the hydration in the discs. So it helps creating that cushion and making it more more supportive of the bones. It also helps create this environment in the disc, which makes it more conducive for healing. It attracts cells that are involved in healing to go into that area. And also there has been studies that it showed proliferation in the cells of the discs, what we call the nucleus pulposus, which is in the center jelly-like material in your discs. So there's a lot of ways where it can help, and basically it helps put your disc into a state wherein it can be more conducive for healing and prevent further degeneration.
And this is very exciting to us because, first of all, as we mentioned, most people in America will get back pain at some point in their life. At least half of those patients have some form of disc degeneration of one degree or another. And the treatment options are pretty limited. You know, like I said, I've been treating the spine since the early 90s. And, you know, we had cortisone injections, we had physical therapy, we had pills, and we had surgery. You know, if the surgery had a high success rate for disc pain, you know, we'd probably recommend it more. But the reality is the published clinical studies show that the success rate of fusion, even though the actual fusion is successful, the patient actually fuses 98, 99% of the time. The relief of pain is more in the 50, 60% range. So we really kind of had this gap in care for so long, where if you didn't improve with physical therapy or other non-surgical options, you know, and then you had surgery at the other end, for those folks who weren't quite ready for surgery, who didn't want surgery, maybe surgery was not indicated, they just suffered, you know, and unfortunately, a lot of these patients ended up taking narcotic pain medications, and that created a whole different set of problems. So along comes PRP and cell-based therapy, you know, 15 years ago, and showing very promising results. A number of studies, Dr. Patin out of Colorado has a study where a bone marrow aspirate concentrate was injected into the disc. These patients have now been followed for more than 5 years, and with significant decrease in pain and significant improvement in in function, as measured by what's called the Oswestry Disability Index. So the challenge with these studies is that they are case series, right? So there aren't placebo controls, and we know that patients can respond to placebos. One of the questions here is, what do you think about the Mayo Clinic study where patients showed significant improvement when they had water injected into their knee? And the answer is that salt water injected in your knee is actually not a placebo, it's actually a treatment. It's a pretty weak treatment. It doesn't last very long. It's probably not as good as steroids. It's probably not as good as gel injection, but it does have, for some people, a beneficial effect. And so there's a lot of debate amongst us researchers as to whether or not we should even consider normal saline as a placebo anymore. But the point is, we need those studies. We need to compare the results with these new cell therapies to standard of care, to placebos, so that we can really have an understanding of what the impact is, what the benefit is.
So this intervertebral disc, or this cushion between our bones, they can create these cracks, as we were talking about, called annular tears. And this creates an inflammatory response, and that can create back pain or neck pain. Another way that it can cause pain is it can actually cause a leakage of these inflammatory chemicals into the epidural space, or that space in your spine where your nerve roots are. And that can cause symptoms that, you know, what we call a sciatica, or nerve pain down the legs. So Another treatment that we do to address disc problems with sciatica is to do an epidural injection of PRP, or platelet-rich plasma. And that helps by decreasing the inflammation around the disc and the nerves, but it also helps with nerve repair, and it helps create this environment where the nerves can heal and not progress in its degeneration. So to answer this question, is PRP epidural more effective than a traditional epidural steroid injection? There's, in fact, many studies that have compared epidural PRP injection to traditional steroid injection, and the PRP epidural treatment fared better, not just in the response, but also in the longevity of the treatment. It lasted longer than traditional cortisone, which typically lasts only about 3 to 4 months.
And that's a pattern. It's a pattern that we've seen with other studies, you know, whether it's a knee arthritis study or a hip arthritis study or an epidural injection study. In general, steroids work quickly, you know, within a few days, but they don't last very long, typically, which we wouldn't expect because the drug gets metabolized within, you know, days. The PRP also gets used within probably 2 weeks, is probably the maximum that PRP would stay in an epidural space or in a joint. But it creates this cascade of biologic events that seems to promote further healing, further control of inflammation. It also modulates the immune system. So some of these platelets, growth factors, and cytokines that were released will actually talk to T cells and modulate the tendency for those cells to create inflammation. So in general, we say, you know, steroids a quick fix, but it doesn't last very long. PRP actually is the opposite. It takes some time to work. Sometimes we see quick response, but more often than not, it takes several weeks before we see improvement. But the results are long lasting. I mean, I think my record for one patient is 4.5 years with a single PRP injection for very severe bone-on-bone knee arthritis. So that's an outlier, you know, but you know, results vary from patient to patient, but that's a general tendency that we see when you look at PRP versus steroids. PRP is almost always superior at 1 year follow-up, even at 6-month follow-up compared to steroids.
There's a question here, Dr. Rogers, with regards to treating facet arthritis in the spine. Is facet,
yeah, facet joint, for those of you who don't know what the facet joints are, if you look at the skeleton, if you look at the spine, you'll notice that there are bones in there are discs in there, but then on the backside, you've got these joints that we call zygapophyseal joints, or Z joints. In Australia, they call them Z joints. And for those, the rest of us would call them facet joints. So, you know, they're about the size of your knuckle. They're a true joint. Two bones come together. There's cartilage on each surface. There's a capsule that holds synovial fluid in the joint. There's synovial tissue, which manufactures that synovial fluid. Any of those structures can become degenerated or inflamed. And PRP has been shown to be helpful for that. For more severe degenerative changes, we prefer to use bone marrow aspirate concentrate. We seem to get better results with that. The million-dollar question is, you know, there's 14 joints in my low back. Which one is causing my back pain? Well, we can take your back for a test drive. We can inject a little local anesthetic into the joint that we think is causing your pain. And if you get at least 80% relief for a couple hours, then that confirms that pain is coming from that joint. Some doctors like to do that twice, just to be extra sure that we know what we're talking about. Some doctors in this field have chosen to forego that, and they just treat everything that looks arthritic on the X-ray or the MRI. I think our community, our medical community, has not quite come to a consensus yet as to what the proper algorithm should be. But I will tell you, as a conservative doctor, my approach, and I know Dr. Ambach does the same, is to anesthetize the joint, identify whether or not it is the source of pain before actually injecting cells into the joint.
Most of the studies on joint arthritis are on peripheral joints, specifically the knee joint. There's a lot more data on using these cell-based therapies for knee joints and other peripheral joints like hip joints, shoulder joints. So most of the data or decision-making that we use on the spine is derived from this really high quality studies. There's level 1 evidence on using these cell-based therapies for knee osteoarthritis, for example. So we have successfully treated patients with facet joint pain, either derived from arthritis or any other problem. And it lasts for several years. Typically, in our experience, it can last anywhere from 2 to 5 years, both in the low back and in the neck, or what we call the cervical spine. So to answer your question, yes, we have used them, and PRP has the same way as an epidural has sustained a longer effect when used in the joints compared to just cortisone.
And I see the question also asks, I see it now, it just asks about sacroiliac joints as well. Sacroiliac joints, of course, are the joints in the pelvis that connect the sacrum to the iliac bones. Not as common a cause of chronic low back pain, but a significant number of patients, including my wife, who suffered with sacroiliac joint ligament injury from a sporting injury. And I managed her back with physical therapy for more than a decade before I finally got the bright idea that I should try PRP. And it's been at least 7 or 8 years since I've treated her. I treated, actually, I didn't even inject the joint. I injected the ligaments because that was her problem. PRP has been shown to be very helpful for tendon and ligament injuries. And so even though at that time there weren't any studies on the sacroiliac joint ligaments, it just made sense to me to try it. It was safe. She was willing. She'd been fed up with her back hurting her for 10 years. So she's done very well. We've had, like I say, 7 or 8 years of great back pain relief. She's got some other things I need to treat now, but not her back.
Yeah, there's actually a study that I can think about with the SI joint, comparing the use of steroids in the SI joint with PRP. And in this particular study, the steroids decreased the SI joint pain by about 20-25%. However, the PRP decreased the SI joint pain by 90%. So quite a big difference there with regards to efficacy. There's a question here with regards to multiple facet joints, which I think Dr. Rogers has answered, and sacroiliac joints as well. One thing that I want to add with the sacroiliac joints is these are big joints that are in the sacrum, and they have a lot of ligaments that support them. And most of the time, whenever a patient comes in with sacroiliac joint problem, it is a dysfunction of the structure, not just because of the joint itself, but because of ligamentous laxity, which means that the ligaments that support these joints are loose. So most of the time when we treat this structure with cell-based therapies, we not only address the joint, but we also address the supporting ligaments and to keep them healthier and tighter. All right, next question, Dr. Rogers. Are PRP or cell-based treatments effective where a patient has had a fusion that did not relieve pain?
So this is a common scenario that I see where a patient maybe had a fusion between L4 and L5, and we know that the incidence of adjacent segment degeneration is several percent per year. So what that means is that the joints and discs above the fusion and the joints and discs below the fusion are now taking on a little extra load. There may actually have been some injury to the ligament or to the muscle during the surgery itself, or even just as a course of the natural degenerative process of disc degeneration. And so that's why I think the long-term success rate of a spine fusion is so low. There's so many parts in the spine that could become a secondary source of pain. And we absolutely have treated these patients. The trick is to identify what the source is. In some cases, there's a disc that had a tear in it that was not known because the MRI didn't show it, and we discover it after the patient's already had their spine fusion, or they've developed arthritis. Very commonly, I see that L4-5 gets fused, and then at L5-S1, you now have arthritis rather of those joints because you have a fused segment, and then you have the pelvis, and you have this very mobile intermediate part that just degenerates. And we treat it really no different than any other patient who didn't ever have a spine fusion. It's just we have to work a little bit harder to identify the source. I've even had some really odd cases. I'll just add, if there's any doctors in the audience, you may have seen this, although it's not in the textbook. I'm pretty convinced that in the absence of disc degeneration or joint arthritis, you can still have ligament injuries in the spine. You can have tendon injuries. After all, there are several muscles that attach to the spine. I've actually seen some tendon tears on ultrasound. Surprisingly easy to treat once you find them with PRP, actually. And so I've had a few patients where their spine fusion was fine. You know, they had 3-level fusion, no adjacent degeneration of the disc or joint, no issue with the sacroiliac joint, but they have these kind of lingering tendon injuries, you know, relating to the muscles of the spine. And I've treated those with better than expected results.
So we might have just enough time to answer one question, but we just want to remind you that we do these sessions every first Wednesday of the month from 12:30 to 1. So if you did not get an invite, you can log on to our Facebook page and just join through our live session through our news feed. Otherwise, you can watch out through all our other social media channels with regards to how to link through us through Zoom and join us through Zoom. So every first Wednesday of the month, 12:30, we have special topics each session. And this session, we were discussing spine pain. And our next session is on January 6th, and we will send you information on what our topic will be. So I'm sorry if we didn't have time to answer the other questions that relate to other conditions, but we will sure to include those for our next session. Very quickly, Dr. Rogers, there's a question here about amniotic fluid injection, and we'll take that as our last question. What it is.
Oh, my favorite topic. Yeah, very long story short, whenever we use cells or tissues, we prefer to use your own, and that's because at this point, the FDA has not approved any donor-derived product for orthopedic use. There are cases where obviously you can store your child's umbilical cord stem cells, and that's perfectly fine. That child can only use those cells if they have an FDA-approved application. So if they have some rare blood disease or a blood cancer, that child's umbilical cord stem cells cannot be used for brother or sister or mom or dad. They can only be used for that child. And someday we will have FDA-approved products, but at this point we do not. The reason it becomes a question so often that we hear from our patients is there are clinics who claim to have stem cells in a bottle from umbilical cord, blood, or placenta, or amniotic fluid. And very long story short, there are no living cells in those bottles. Even if there were, they were not permitted by the FDA because they have not been tested for safety and they've not been tested for efficacy. So any claims that the doctor makes about such a product are false. And you should avoid doctors who don't tell the truth.
That's great, Dr. Rogers. That's a great end to our session. So thank you everyone for joining us in this live event. And as I said, every first Wednesday of the month at 12:30, feel free to join us through Facebook or through our other social media outlets. Thank you, Dr. Rogers, for joining me. And till next time, January 6th will be our next event.
See you then.